Trust, and this is the 62nd meeting of the Council of Governors of Oxley's NHS Foundation Trust. We start with apologies for absence. Do we have any, Jo?
We do, Andy. 2 seconds. We have apologies from Michael Earnshaw, Mark Ellison, Mark Goblow, Kate Heaps, Carl Crowhouse, Ravimbo Muttimbezi, Raja Rajendran, Amlan Basu and Sarah Birchall. Thanks very much.
As I say, welcome everyone. Richard, this is your last one, isn't it? Your last Council of Governors, and you know, a big thanks to you. I think you've been an outstanding lead governor. It's been an absolute pleasure to work with you. You've been a great source of good counsel, and I think you've steered a very clever and intelligent path, I think, between your role as a councillor in Bexley and your role as lead governor for Oxley's. And we will definitely miss you in this role. So a big thanks from us all for everything you've done for Oxley's over many, many years. Now, how many years is it now, Richard?
Well, it's 9 years at the AGM. I was just working. This will be my 36th meeting of the Council of Governors.
Wow.
I think. So, and I will miss Oxley's or my engagement in it at this level desperately. I'm sure I will find other things, and I'm of course not disappearing completely because you refer to my role as a councillor. I chair the Health Overview and Scrutiny Committee in Bexley, so I shall be continuing to watch very carefully. And of course, Queen Mary's Hospital sits in the middle of my ward, and hopefully, if I'm re-elected next year, I will continue to be the councillor for Queen Mary's Hospital.
Well, thanks again from us, Richard. I'm very, very grateful indeed. We've had an election for lead governor, and congratulations to Sue Salter, who's been elected as lead governor. Really pleased to have, we had two very, very good candidates. I was so pleased that we had two people of such caliber step forward, and I'm very grateful for that. And thank you so much, Sue. I look forward to working with you. So, did you want to say anything, Sue?
I have a huge act to follow, and I'm not quite sure if I can. I will do my best.
Well, you're very, very welcome, and thank you so much for that. We have the minutes of the last meeting, which we'll just go through swiftly, because if you had any major problems, you would have raised them already. But anyway, 1, 2, 3, sing out, folks, as I'm going through. 3, 4, 5, 6, 7, 8. I'm getting an echo here. 9, and as we have somebody, Azra.
Hi, thank you. I'm actually on page 6. You kind of speeded through them so fast, so we can just go back to page 6. And we're on the third bottom paragraph. Can we just put a stroke between the I and the E in NHSIE?
Yes, I'm sure we can.
And also on the next paragraph, where we refer to directors of finance and chief financial officers, it should say, as opposed to the singular.
Right, okay, thank you.
Thank you.
That's page 6, page 7, page 8, 9, 10, 11, and 12. Was there anything from there at all? If not, Azra, your hand's still up. Is there anything else? Azra, did you? Right, okay, thanks very much. Any matters arising from there anyone wants to raise? If not, we'll go on to item 4, which is the Chief Exec's report from Ife Okocha. Ife did speak at the informal beforehand, but formally welcome Ife in the chair at the moment as interim Chief Executive. I almost want to thank Ife. Ife is on his annual leave at the moment with some very, very pressing engagements he has to attend to, and I'm very grateful for you giving your time today, Ife. And over to you for your report.
Thank you so much, Andy. That's really kind of you. So I'm going to assume that my report has been read, but there are just a few things I want to draw attention to. We've already in the pre-meet talked about my role and Matthew's departure, so I won't touch on that. COVID, as everyone knows, is still very much on us. Can you hear me? Oh, bit of an echo. Okay, COVID is still very much upon us. And for our staff, we're encouraging infection prevention and control measures and twice weekly lateral flow testing. Since this report was written, we've unfortunately had what we describe in public health terms as an outbreak on one of our wards in Bromley, which involved 3 patients being positive and a couple of our staff. And as a result of that, that ward has been shut for admission and will be for a couple of weeks or so. We're still trying to figure out where the infection came from. Our optic of the vaccine is really good. I think it pretty much shadows the national optic, where we have over 80% who have already had their first vaccination, and over 70% have had their second. And we continue to encourage colleagues to either have more of their first or certainly have the second vaccine. It wouldn't surprise you to hear that we're also involved in the new government's initiative to vaccinate 12 to 17-year-olds. And my colleagues in the Children's and Young People's Directorate are leading that with the support of all system partners. So flu vaccination, we begin 4th of October. Already had a conversation with both doctors and our senior staff. The target this year is an impressive over 85%. So we've got a way to go. And I hope that our experience of COVID will motivate those who have typically not been keen to have the vaccination to turn up and have the vaccination. Just to draw your attention to the publication by NHS England London region with UCL partners about what we've learned so far from the COVID vaccination across London. So the evaluation report, I think it's worth reading. There's some really, really great insights there that I have no doubt will help us going forward. And then a note of, on a positive note, Greenwich did receive an award, the COVID-19 Response Champion Award from the mayor back in August. At the end of this month, we reconfigure our services. So Bexley, Bromley and Greenwich directorates will cease to exist, and we'll have 3 directorates replacing them: adult acute and crisis, adult community mental health, and adult community physical health. That said, we will still maintain our focus in each of those boroughs, not least because the ICS will require us to do that, given the way that we are going to be working, particularly from April of next year, where the place will matter hugely in terms of services that we provide, mental health and community health. And so the view is that we have to agree, and indeed we have agreed actually, which of our service directors are going to represent us at place. Would like to extend my invitation to you. There's an event on Tuesday, 28th of September that I'll be hosting Professor Michael West, who has done quite a lot on leadership, has written extensively through the King's Fund, and we'll be talking about compassionate leadership and how we can practice in that way in Oxley's, partly to help support our staff at a time that they have been, that they will continue to face challenges, as I said at the pre-meet. I don't think I need to say anything about the South East London ICS. I think all of that has been covered earlier. And South London Listens is just something else that we've been part of and have agreed the role that we will play going forward. One or two final things to say. Afghan refugees, you may or may not know that there were no less than 700 of them in the Intercontinental in Greenwich, and Oxley staff contributed in lots of ways, both in terms of volunteering to help distribute clothing that people had donated, but also in terms of supporting those with psychological difficulties along with our partners in SLAM. That would all have ended yesterday. We know that bridging hotels are being sought for some of them. We don't know of any bridging hotels as I speak, none in Greenwich, Bexley or Bromley, but I think there are a couple in Southwark. But if there are any that pop up in our patch, we will no doubt continue to support them. So I think that's all I want to say, Chair. But I'm happy to take questions either based on what's in the papers or if there are any other questions that colleagues will want to ask me.
Thank you, Iffy. Any questions, please? I can't see any at the moment.
Ray
Ray
has his hand up, Andy.
Ray, please.
Hi, thank you, Andy. Hi, Iffy again. Thanks for that. Just 2 points. The first is about Michael West. If he's the Michael West who I think he is, he was the guy who did a wonderful, chilling equality impact analysis for when the RES system was about to be introduced. So if he is the one, I think he is. So when he comes to talk to you about compassionate leadership, really worthwhile getting hold of that equality impact analysis. It just didn't deal with race and ethnicity. It covered all the protected characteristics, and against the backdrop of everything that Oxley's is trying to achieve through building a fairer Oxley's. Maybe it's useful to ask him to say a few words about that. If he is the one, but I think he is. And
I'll certainly ask him, and I will have him say a few things.
Yeah, and the second point, if he was that in your chief exec's report, you say that visitors are asked to wear masks and keep their distance. You say that staff are asked to do twice weekly lateral flow tests. But the thing is, do they? Do visitors wear masks? Do they keep their distance? Do staff do the tests?
So that's what we ask them to do. Can I be 100% confident and say to you that it happens all the time? No, but it is something that we're constantly pushing. I don't know, Abby, whether you're able to say anything about what happens on your ward, with respect to visitors and staff. I see you are on the call.
Yes, on my ward, which is Holbrook ward, and all inpatient wards, as far as I know, all visitors have to wear masks unless they're exempt. And even if they're exempt, we would be encouraging them not to visit. So all visitors have to wear masks. All staff definitely wear masks. Whether they do the lateral flow test, I think possibly a good proportion, but I wouldn't say 100%.
Thank you, Abby.
Richard, please.
Thanks. Sorry, couldn't find my mute button there for a second. I don't want to anticipate grief, but I was involved in some discussions a few days about concern about the deadline that was passed yesterday for care home staff who should have had their first COVID vaccination by yesterday in time to have the 8-week break before they have the second vaccination to be able to continue to work from sort of mid-November onwards. I think if we're realistic, given the consultation the government have now got out, they're quite likely to adopt a similar policy for all NHS staff at some stage. And I know we have very high levels of compliance with having had the vaccine amongst the Oxley's workforce. But have we got any contingency plans in place for if a decision is made, and I think it's quite likely to be made by the government over the next few weeks or month, or so to move toward compulsory vaccination, about how we might ramp up that campaign and how we're going to cope given all the problems we have about sort of workforce numbers that are on a knife edge anyway.
So can I just take that in two parts? I'll invite Ian to comment on what we're doing about our staff in the context of care homes. I don't know that the government has any plans to make vaccinations compulsory for NHS staff. I really, everything I've heard so far is that the government is quite hesitant about that, but I stand to be corrected. That said, I know that Ian, as Gold, has really been pushing for our staff, particularly those who have reason to go into care homes, to be vaccinated, because the one thing we don't want is for them not to be able to do that, and therefore the burden of that work falls on others. Let me invite Ian to comment on that. Ian.
Thanks, Iffy. Just to return to the issue of whether NHS staff, it will be mandated that they're vaccinated. There is actually a consultation live at the moment, which has been shared in One Oxley's for our staff to comment on. So it's actively being consulted on at the moment. But what I would say is that up to now, I think there's been a huge amount of hesitancy about it being mandated. In terms of our staff accessing care homes, as you've outlined, Richard, deadline passed yesterday for care home staff, and this new regime comes into play in November. We do know how many of our frontline staff have been vaccinated, and we can break that down into first and second vaccination. We've broken those lists down by directorate, and they have been shared with each directorate so that they can interrogate that list. And the idea behind that was to see if we could close the gap between those that have had just one vaccination and those that have had two. And that work around cleansing the data has closed the gap quite significantly, but there is still a gap. So access to care homes, most of our directorates have some access as part of their kind of clinical work into care homes. The rates of kind of one or no vaccine as opposed to two varies between directorates, but they have a much better idea as we head towards November. Contingency plans are being put into place, so work will be redistributed, and they are able to escalate to me if they find themselves in a situation where they're not able to cover the work within the directorate and they need to go beyond that. But at the moment, I'm fairly confident we will be able to manage come November, and we're certainly plugged into the local borough-based kind of multi-agency conversations around this.
Thank you.
Thanks, Ian. Nina, did you have your hand up?
I did, Andy, but only to share a patient perspective as someone who spent about a day in A&E in QE recently on the question of masks. So I was just going to say it was a very variable picture, and having lived through or seen some of the pressures that they're under in a kind of real-time way, I think it would be incredibly difficult to mandate mask wearing for some of the people that were coming through the door. So that was just a patient experience.
Thanks, Nina. Anything else for Iffy? If not, thank you very much indeed, and we'll see you soon, Iffy. All right,
Thank you. Bye now.
Thanks very much. We'll go on now to item 5, which external auditors. Stephen Dilworth, please.
Thank you, Andy, and good afternoon, everybody. Grant Thornton will be handling this presentation in a minute, and Grant Thornton, of course, are our external auditors and will be well known to you. They've made various presentations to the Council of Governors over the year. And Sarah Ironmonger is our lead auditor, and Sarah has done a very professional and great job for us since Grant Thornton were appointed. They're now entering their 4th year of their contract with us, and that means over the next 12 to 18 months, we will be reviewing that and possibly looking to invite others in for a tender. Governors have a very important part in that process because, as Richard knows, we usually invite at least the lead governor to be on the interview panel. And also governors have to approve the final appointment. So external auditors are very important in their relationship with governors, and they can, if they so wish, report directly to you if they have any concerns. Just to recap on what external auditors do, and I think you'll be well aware of this, but they evaluate our financial controls. They make sure that we've got efficient use of our resources and value for money. And Sarah, I think, will comment on that because that's been an expanding area. They assess our internal controls. They audit our financial accounts for the year. And very importantly, as well as providing this annual report, they also look at our quality accounts, but also notify us of what they see as emerging issues. And this could be just within the organisation, but they may be looking at the sector as a whole. So that's a very good information, both for us on the board, Oxley as an organisation, and for yourselves as governors. So without further ado, I will now hand you across to Sarah.
Thank you, Steve. So as Steve said, I've got a very brief presentation. I think if we could, Joe, if we could move to the next slide. So this is just what I'm going to cover. I've not got lots of slides. I've just got this one because just wanted to give you a very brief summary. So we did do our financial statements audit and we gave an unmodified opinion on the 28th of June, which was within the timetable that the NHS set. And then we moved on to do our value for money conclusion work. Now the deadline for that is the 20th of September, but that has all been done with the certificate issued. We did that in July, so you were well in time for that. What I wanted to talk about was a little bit more about the value for money. Attached to your pack, you've got the full annual auditor's report, which is a lengthy document, so you'll be pleased to know I'm not going to go through page by page on that, but it is changed from the previous year. So there's the National Audit Office set a code for all auditors working on NHS audits, and previously the approach per the code was to do a risk assessment, and then when we found an area that we were concerned about, then do some work on that. But actually, if our risk assessment didn't identify anything, then that's where we stopped our work. The code has now changed and we're required to document your arrangements and provide a commentary on that on the first three areas on that slide. So financial sustainability, governance, and improving economy, efficiency and effectiveness. And for 2021, there was also an additional area of COVID-19. So what we're pleased to say is we didn't identify significant weaknesses. This is audit terminology. In the past, we talked about giving a qualified or an unqualified value for money conclusion. That has gone. We now talk about significant weaknesses or no significant weaknesses. So we didn't have any significant weaknesses. What we do have is a number of improvement recommendations. Now, some of these are things that we think perhaps you could do just a little bit better. Some of them are forward-looking about actually as things develop, this is what you want to be looking at. And just because there's a little bit more detail, I thought I would take you through some of that. So the first area, financial sustainability. Many of you will be aware that the NHS changed the business rules to respond to the pandemic, and you adapted well to those. You do have a strategy in place for the next few years. And one of the things that's been happening as well as responding to the pandemic is moving ever closer to working as a system. You have identified a need for savings and you have been delivering on them. And really the only improvement recommendation is really around those savings and how you develop recurrent savings. So ones that continue to deliver savings rather than the ones that just meet that financial year's need, because that gives you a chance to transform your services in a different way. So that's an improvement area rather than something that we say is wrong. The next area we looked at is governance. And in terms of governance, you do have a board assurance framework, you have a risk management process and all that, and we looked at how all that information flows through from committees into the board. We do have a couple of improvement recommendations. So when we looked at the board assurance framework, a little bit about how you show the impact of the mitigating controls you put in. So you have a risk, you put some controls in place, actually what impact do you think that's going to have? And then really just suggesting that as you have more management capacities, you come out of the pandemic, is to look and refresh that board assurance framework so that you can have a really clear focus on what the key risks are. This is perfectly, we see this a lot, that you gradually expand the number of risks you've got, but every so often you need to have that pause, that step back, refresh about, actually, are we really focused on the key ones? We also had a look at performance reports, and you do integrate your operational and finance performance together, and it's very detailed, and there's a lot of information in there. And I think our improvement recommendation was really just stepping back, having a look on that, and can you focus those performance reports perhaps on the areas where as the board you want to be looking at those areas that are slipping away from where you want them to be, so that you focus the time that you have on it. Again, there are proper arrangements in place. These are just our suggestions of how they could be improved. There is also a section in there around the partnership working, and you've referenced it already earlier today, but working together with the South London Partnership, with the other mental health providers, but also as the integrated care system develops, that are taking place, formally starting in April 22. There's more and more work that you're doing together. Now, we think what you're doing we think you're doing a good job with that. We know the executive officers are really engaged in this place, and you have a partnership committee in common, and really it's around how does everybody know what those decisions are that are being made by that committee. So it's just how does that feedback loop work through. So that's really where we talked about that, and that's very much in that space of this is going to get more and more important. So developing your arrangements as the situation develops. And that really sort of covered into where we were looking at improving economy, efficiency and effectiveness. So there's quite a bit that overlaps between those. We also had a look at how you respond to serious incidents. Now, obviously, you don't want to have any, but if you do have them, how you learn from them. And we were able to track through actions that you were taking to address those and learn lessons. And then the final area, because of the situation, we had a look at how you adapted your arrangements to respond to the pandemic, and you've come up. There's some good things that we saw around some of the risk assessment tools, and just suggesting that actually you've got some really good practice in there, but you could look to grow and build on that. So I think that's all I was going to say. It's a really quick canter through what's a lengthy report, but really happy to take any questions.
Ray, please.
Thank you, Sarah. It's Ray here. So, Sarah, when you looked at the bath, did you come across, and I know you did, risks that have been risks for ages, for years? And what did you think about that? And can a risk that's been a risk for ages still be a risk?
So there are always going to be some risks that remain for a year. It's about how are you updating, how are you responding to those? What might be a risk that's been around for a long time. So there are some parts of your system that will always remain a risk, always going to wanting to keep alert to how do you respond to particular issues. So I think we'd be concerned if the risk stayed the same, every control, and there were no real updates. What I think what we're saying is, yes, the risk remains the same, but actually you are continually changing and adapting and trying to address the elements of that as it develops. So it's a bit of a it depends a little bit. Ray, I know you've seen many BATs in your time, and I think it's just really around making sure that there's a clear focus on those key risks and what are you doing? Are you doing everything within your control? And that's a key focus.
Thanks, very helpful. Thanks.
And Ray, if I can just add to that, I know it's a very good question and one that you and I have discussed before. As Sarah's rightly said, the risks have in fact certainly in their nature changed over the years, and what we used to have was the original date when that was put on. In fact, we have now changed that, and and Azra may want to comment on this, but if you take the finance risk that we've now got, for example, that's dated to this year, even though sort of savings has been a regular issue for some time. But we decided to make it clearer. It does differ from year to year. The finance risk is a good example where we've redated it. Another example of how it changed would be something like recruitment. You know, we would have, if you looked at, say, our BAF for about 5 years ago, where we would have had the problems with recruitment on it, it would have been very much about the time to get references and the time the recruitment process took. And if memory serves me correctly, on things like prisons, that could be up to a year, particularly a place like Belmarsh, which you'll know well. But that time has now reduced quite substantially because we've improved our processes and working with the prisons to try and make them more effective. The other interesting thing I would say is certainly on a fairly recent internal audit report by KPMG, our internal auditors. They gave us significant assurance, which is the highest mark for our risk maturity. And that they actually particularly commented on the work we do on the longevity of the risk, the fact that we show when it was first placed on the register. And they said that they don't always see that, but that they found it quite a useful thing to be added to our analysis.
Thanks, Steve. Thanks, Sarah. Good to know. Thank you.
Thank you, Stephen and Sarah. Any other questions at all? If not, Sarah, thanks very much indeed. And thank you, Stephen. And we'll move on to the next item, which is item 6, membership strategy. Rebecca, please.
Thank you very much for that. We're looking at the membership strategy today. And as you can see from your packs, you've got copies of the draft membership strategy, and we're on version 1.3. As the numbers indicate, we've had version 1.0, 1.1, 1.2, so it's developed, and essentially it's designed to support our interests, the legal duty to represent our members and public, and we contribute towards a strategy for Oxley's, and we support the Council of Governors, especially in light of the ICSs that are emerging. And this is an ongoing process, because we're looking towards the government will put the ICSs, there'll be more clarification about how that will work for governors in the future. So the 3 main strands, so we're looking at recruit, communicate and engage and involve our members. So this strategy runs for the next 3 years, and it shows what our success would look like, how we're delivering it, and how we know if we're doing well. Some of the modifications through the development have been about putting percentages of target constituencies. So we want to work with our service users and carer interest group, but we wanted to put a figure on how many more members we'd like to recruit, and again on the public, because we're looking particularly at the children and young people public, and we're looking for a 10% increase in there. So the details are on there, and there's also within that the appendix, which has got the opportunities for service users and carers and how they can be involved with Oxley's. So I'm happy to take any questions if there are any.
Thanks very much, Rebecca. A lot of work gone in there, so very grateful to you and your colleagues. Are there any questions for Rebecca? We're being asked to approve this strategy, are we not?
Yes. Yeah.
Any questions for Rebecca? I can't see any, so again, I'll repeat my thanks. There's a lot of energy and effort gone into this, and thank you very much for everything, as I say, you and your colleagues are doing on this front. Suzanne, please.
Yeah, I'm sorry, Andy, I didn't get my finger onto the button quickly enough. It was less a question, actually, but more to just say how pleased I was to see that part of the strategy that looks at how we can boost involvement and co-production, using the sort of governors as a gateway towards that, but also working and sort of developing it, within the kind of executive team as well. So I was just really pleased to see that, and I'm quite optimistic about where things might go in the future. So thank you.
Oh, thank you, Suzanne. That's really appreciated. And I know that the governors
I lost you there, Rebecca, unless that was just me.
I think we've lost her.
All right. Yeah, just lost you there for a moment, Rebecca. But anyway, repeat our thanks for everything that's being done. And then we'll move on, please, to item 7, which is the Oxley strategy. Rachel, please.
Thanks very much. So this is just a quick update on where we are with a 3-year Oxley strategy. So a reminder, we launched it in April. It was built on a lot of engagement with communities, patients and staff. And I do really want to call out the big role that governors played in the engagement on this and the contribution of you. So a big thank you to you all. The purpose of the strategy is to identify the areas that we really want to focus on to make the biggest difference. And we've identified 3 big priorities. So the first is zero delays. The second is delivering great out-of-hospital care. And the third is making Oxley's a great place to work. And hopefully, as you've read the strategy and you've seen the detail behind these ambitions, you'll see that they are really ambitious in scope. Hopefully, they'll be transformative about the care that we provide and the organisation that we are, but they will need a huge programme of work to bring them to life, and we're really getting started on that. So I'm here presenting today, but designing and delivering the strategy has really been a whole team effort right across the whole executive. And over the last few months, we've really started motoring it, and there's been some fantastic leadership by Dr. Abby Fadipe, who's on the line, and also Lorraine Regan. You'll have read the paper with the detail about each of those strategies, but I wanted to highlight that it's also really important, building on the point that Suzanne just made actually, that we use the strategy and the development and delivery of the strategy as a way to make sure that we really embed great service user, patient and carer involvement and co-production in all that we do. And also that we engage all of our staff, because we really need a lot of energy to deliver a change of this scale and ambition. And we also want to make sure that we make full use of quality improvement and all of the insight and the levers that we have. To be honest, we want to use all the levers at our disposal to try and deliver these outcomes, because we think they're important, but they are really ambitious. Throughout, we'll be keeping the board, our committees and the Council of Governors updated. So if you ever have any questions, please do get in touch. That's all I was going to say, Andy, but I'm very happy to answer any questions.
Any questions for Rachel at all on that? Again, I'm very conscious of the huge amount of work that's involved at a time when everyone's exceptionally busy. So, I think we're very grateful for the energy put into driving this along, because clearly we won't lose any momentum on this, but I'm very conscious of just how the demands, particularly on all of the senior exec at the moment. If there are no questions for Rachel on that, we'll move on to building a fairer Oxley's. Nina and Rachel. Nina, are you going to start on this one?
I'm happy to make some introductory comments, Andy. I think I wanted to start by saying, and I think it's apparent in the papers, that the areas that we are trying to address with the work that Rachel's outlines in this report, whether it's around the RES or the DES and the Building a Fairer Oxley's work streams, the areas are complex. They're entrenched. They've invariably built up over a period of years, and often before any of us join the workplace, but they clearly start to manifest in different ways once people do. And I think they're multifactorial, so they need a thoughtful approach in order to be able to result in sustainable change and change that is meaningful. And I wanted to try and provide assurance on three things. And forgive me, because I know I've touched on some of these in previous meetings, so there's an element of repetition, but I continue to be struck by the absolute commitment, the resolute commitment of the board, of the exec, and of staff in trying to address these issues, not with a sticking plaster approach, but actually in a way that really gets under the skin of some of this stuff. And the second point is the thought, the care and the energy that Rachel and her team have put into this from the very beginning and continue to is something that is way beyond anything that I've seen anywhere else. And for me, the most important aspect of their work has been that the starting point has been to really try and understand and really try and listen to understand before tackling the issues. And a big part of that has actually been very uncomfortable and very difficult for a lot of people involved. So it's absolutely been the right approach, and the focus coming out of that work has been severalfold, and rightly some of it has been on balancing the need for staff to be able to see and feel that things are different on the ground, with the need to actually drill down into some of this stuff to be able to come up with the more structural solutions that are going to be take us to longer term change. So those are the kind of overriding comments that I thought it might be useful for governors to hear from.
Thank you, Nina. Rachel?
I suppose all I really wanted to add to what Nina's helpfully set out is that we are required to report publicly on performance in relation to two specific characteristics, which is race and disability. But they are only two parts of a much bigger picture. So we know that people also have different experiences based on sexuality or gender or religion and age. And just wanted to reassure the Council of Governors that we're looking at all of those experiences as part of our Building a Fairer Oxley's work. And we are developing a really robust, slightly scarily ambitious action plan for the coming year that looks at everything coming out of the data that you have in front of you, as well as an engagement that's touched hundreds and hundreds of staff over the summer, as well as directly with each of our networks. And we've brought all of that together into a one-year plan for year 2 of Building a Fairer Oxley's that we'll be about to launch. That was all I was going to say. Thank you.
Thanks very much, Rachel. There's obviously been a huge amount of work. Where do you see the challenges at the moment, in the sense, where are we not doing so well?
So the biggest area is in relation to the overrepresentation of Black, Asian and minority ethnic staff in our disciplinary procedures. And we thought we were making progress on this, but it's slipped backwards over the last year, and that's just not something that we're willing to countenance. So we've joined an NHS Improvement in England new Vanguard group that are looking at deploying the best practice. We're working out where our specific issues have been, and prisons have been a specific problem. We're looking to make sure that our approach, building on just culture, is embedded at all levels, and we're taking all of our panels through a training process. But we want to be, and there's a lot more that I could go into. I could talk about this for a very long time. We've had some very useful deep dives with our NEDs, and we've had good discussions at Workforce Committee. We engage our networks in looking at our performance so that they can really challenge us on some of these areas. But it's not good enough, Andy, and it's something that we want to be different by this time next year. That's my biggest area of concern.
Yes, I mean, it's an interesting one. It really stands out, doesn't it? But I mean, not that we worry about how we compare, but how do we compare? I mean, is this something that is across the NHS? Because it certainly appears in many other organisations as well.
Yes, I mean, we're pretty much middle of the patch when it comes to it, which is not where we want to be. There are other organisations who have a worse performance, notably some of our neighbouring trusts, but there are a number that manage to crack it much better than we do as well. So, you know, I don't want us to be being complacent on this one. I don't want us to be trying to give ourselves excuses as to why our numbers where they are. I would much prefer us to have a really robust programme of work that's going to fix this over the coming year.
Yes, thanks very much. I say it really stands out, doesn't it? There's lots of good progress, but that one sort of leaps off the page at you as where we went forward, and then we seem to have gone back a bit. I was just wondering, perhaps maybe for the next Council of Governors, we actually devote quite a chunk of time to this, you know, to see how we're progressing. And then really I'll be really interested, obviously I hear from you directly, but maybe the governors will be very interested, no doubt, in some of that detail, in how does this start? Because we can talk about training panels, but that's almost a bit late, isn't it? It's how does this start? You know, how do we get on this track that brings us into this disparity?
Yeah, I think there's something about how we approach different areas. One of the things that NHSIE are suggesting is that we reserve disciplinaries for only a very, very narrow category of cases, and that's something we really want to actively consider, because I think a disciplinary doesn't help the organisation, and it really doesn't often help the individual either. There are often far better ways that embed that practice going forward. We are already trying to make sure that we only go to disciplinary where we are sure that you know that we've looked at all of the mitigating factors, did the person have the right training, what was going on the day, what might have led to it. We try and build that in, but I think we can be even more consistent on that approach.
Good, thank you. I mean, I think I would like us to spend some time on this next time round, because I'm sure that by looking at the number of questions you've got coming up, the governors are very interested in this. We'll start with Sue Salter, please.
Interesting. Andy covered one of the points I was going to ask about comparisons, and I think it was always taking comparisons in many ways. Certainly, I think it's interesting to hear that you're looking at the wider view rather than just the disciplinary, what was underneath that disciplinary, what was the cause, and all the other issues with it. And certainly in my experience, very often it is a lack of knowledge and training that leads to that disciplinary, if that's one way of looking at it. And the other thing I was talking about, do you think, and you know, it's a question, that the shortage of staff and recruitment and COVID has impacted on this at all?
That's a very, very good question, Sue. I think we've seen that, and that what we're hearing back from other trusts, the data hasn't all been published yet, but what we've heard back from other trusts, we discuss this a lot at the HR directors meeting across London, because this is a particularly stubborn thing to fix for all trusts, I think. And we have seen, I think, a number of trusts with their numbers going up overall in the number of disciplinaries that they've had, and that's exactly what we've seen, far higher over the last year than we have done previously. So we don't know whether it is that staff are kind of approaching burnout and feeling so tired that that they're finding it harder to perhaps respond in the way that they might normally do, and perhaps it might trigger those sorts of behaviours. We don't know if it's whether our managers haven't been able to explore other options or provide the support to our staff that they might have needed because of the pressures there. But there certainly has been an increase across the board in the number of disciplinaries that I don't think we can separate from the impact of COVID. Thanks, Sue.
Before I come to others, Nina, as the sort of lead NED from workforce perspective, any thoughts at this stage?
I think the one thing I would draw out, and I do think there's value in drilling down into a level of detail at the next Council of Governors meeting, Andy, is when we as NEDs have got together with Rachel and drilled down into the detail of how did these cases come to be, what was, if there was inappropriate language used, what was that inappropriate language? It just shows you the level of complexity that we're dealing with in terms of some of the underlying issues that are being raised. And I continue to believe that a lot of this will be addressed through the Building a Fairer Oxley's work, but the nature of that work, as Rachel has drawn out in her paper, these are issues that people have experienced over a long period of time. They're not going to go away. If you've had a bruising experience, it's going to stay with you for a lot longer than it takes for Oxley's to introduce a new method of looking at things or a new method of taking things forward, as we have with Just Culture. So my sense is there is a strong element, there is a strong role that the pressures of the pandemic have played. And I believe that my gut tells me that it's got worse before it's going to get better, but that we are on that path to getting better. I would, however, welcome the chance for us to highlight some of the issues that we've discussed in detail with Ned at the next Council of Governors meeting.
Yeah, Mercy, I didn't want to spring this on you, but I was just going through the PCRAC papers and looking at the report on Rochester. And the time a number of issues were raised there, weren't they, in that initial report back in August 20? And it came up again at PCRAC, didn't it, for review? And it seemed to play into this sort of issue. Any thoughts on that at all? Sorry, I can't hear you, Mercy. Can
you hear me now?
Sorry, Mercy, can you hear me?
Can you hear me now?
Yeah, gotcha. Yeah.
Right, lovely. Yes, we did talk about it briefly yesterday in PCRAC, and we are aware that obviously because of the kind of environment that we are working in our prisons, it can make it difficult for us, our staff. There obviously is a link between the way that staff are managed and obviously patient safety. So it's something that I know Lawrence and the prison directorates have been working together to try and solve. And one of the things that constantly comes up is the fact that especially in prisons, the culture doesn't necessarily align with Oxley's main culture. So we are trying to level that out because what seems to be happening is that what's happening centrally doesn't seem to disseminate out there. So we've got to work better on ensuring that we bring our prison staff into the core, because as Rachel was saying, a lot of the data shows that actually those kind of disciplinaries are occurring within our prisons directorate. So I think that would be a good place to start.
Thanks, Mercy. Sorry to keep you. Ray, please.
Thank you, Andy. I want to make 3 points. I'm going to try to be very brief. I just want to start by saying that I've worked with you, Rachel. I've worked with you, Naina, a little bit on this, and your commitment and sincerity on this topic is unquestionable, and I admire it. But here come my 3 points, and I make them as a critical friend. In your Building a Fairer Oxley's report, there are certain things that left me feeling uneasy. First of all, you referenced the staff survey. It's out of date, implying that if it were more up to date, well, it wouldn't be so bad. Then you say that our figures are the same as other London places, which tells me that, well, we're the same as everyone else, so that's okay. And then you talked about people's perception about being bullied and harassed. It's historic and it's built up over time, implying that maybe it's not so real. It's just based on past perceptions. And I don't think those three phrases did you any favors. And I know that you're very committed to equality, but that didn't strike me as all that good. And then if you look at if you look at your charts, if you look at the res, where you look at the charts where you have the RAG rating for the various res indicators, look at the one for res 5. That's people that are being bullied and harassed. Sure, you give the right color for the for the situation right now, but look at the colour you give to the trend. It's green. Well, it shouldn't be at all. The situation right now is awful. Last year, it was a little bit more awful. But to give a trend colour of green just implies it's getting better. How can anyone say that going from very bad to bad is a good thing? So I just think, have a look at the way you describe the trends, because it will hit BAME staff and disabled staff very badly, very poorly. And it implies that things are better when, as I said, going from very bad to bad, nothing to celebrate. There's no green in that for me at all. And my last point is, and I'm glad Yemis is there, hi Yemis, is that I attended PQAC yesterday, and last time at this COG, I talked about the filling in of the quality boxes on the cover reports. And I'd seen some improvement, but yesterday at PQAC, when it came to the integrated board report, nothing was filled out about equality. When it came to all the quality reports, meaningless statements were given, such as equality. You're supposed to say something about the equality analysis. Meaningless statements such as learning from improving practice, promotion of inclusion and equality. It'd be better if they'd written nothing. And I just wonder if some effort could be made to making sure that cover reports are filled in properly, because it would really show a commitment to equality. And those writing those cover reports know what the issues are. Share a little with us and show that you really are concerned about equality and inclusion. There you go, I'm done. Thanks.
Yeah, thank you, Ray. On that last one, you have raised that before, and quite rightly, and I think the other points you raise are very valid. Nina, please.
I just want to thank you, Ray, for being so candid. I personally really welcome that, and I know that Rachel will as well. On your specific points, that the staff survey, there is a sense that we feel the staff survey is out of date. Rachel will come to the detail on this. I think the only suggestion there was to be factually accurate, that the staff survey was carried out in the autumn of last year. And unfortunately, by the time we get the results, we don't believe that the actions that have been taken under the Building a Fairer Oxley's work programme will have actually filtered through. So it was a point of factual accuracy. It wasn't suggesting that we don't take the results of the survey absolutely seriously. It would just be nice to be able to have them, I guess, at a point in time that's closer to when we see them. In terms of the comment around we're not hugely dissimilar from peers, or that perceptions are build up over time, and there's an element of kind of reality check about that. It shouldn't matter, but I think it does, so I'm going to say it. I'm new to the NHS. I haven't even completed 3 years in the NHS, and I know that Rachel is as well. So a lot of this might be entrenched, a lot of this might be accepted for those who have been in the NHS for a very long time. But the conversations that we've had around the board table over the last 12 months have been really quite we haven't minced our words and saying this isn't okay. This isn't, there is an element of feeling amongst those who've been in the NHS for a long time. I know that clinicians have used the words that it's felt as a kind of badge of honour that you put up with a certain type of treatment or a certain level of treatment until you get to a particular level of seniority. And those of us who I think are newer to the NHS have said that's not okay. And that's not okay in terms of staff treatment, and that's not okay in terms of patient treatment. So one of the things that I'm particularly glad that Rachel has been able to take forward, and it's become a broader initiative with the Metropolitan Police, has been Operation Cavall. I'm sure she'll talk to that, because I don't believe that you can detach the role that patients play and the role that staff, fellow colleagues play, and the role that managers play. I believe it's all interconnected. So the idea of unpicking it in the way that we are trying to is to really address the structural and other reasons that contribute to each of those, because I'm not interested in putting a sticking plaster onto this. That's not going to address the nature of the issues. And as someone who is BAME myself and has experienced them, I'm never going to be satisfied with that, either on behalf of patients or on behalf of staff. So I guess I just want to make the point that there is absolute commitment, and nobody's interested in accepting the principle that perceptions can't be changed and shouldn't be changed. Absolutely, they ought to be, but that needs to be based on experiences, which we are trying to change as a function of the various initiatives that are underway. Completely agree with you on the RAGs. We have seen, and I wonder whether Rachel and we need to take this offline. We've seen a couple of iterations of the report that you're talking to, and I think what doesn't come out is it's not fair to say that because the trend is a particular colour, that suggests that we're happy to it. But I can absolutely see that as a reader of the report, you would come away with that impression. So I don't know that in this case, the information that we've provided is particularly reflective of the sorts of discussions that we're having and the work that is happening to try and advance those. I don't know if that's helpful.
That's very helpful, Nina. Yes, thanks.
Thank you. Yvonne, sorry, I've kept you waiting long. I'll come to others in a moment. Yvonne, please.
That's quite all right. Thank you. Yeah, I just wanted to pick up on a kind of another wider point. I was looking at the res indicators 6, 7 and 8 on page 9 and 10. And I know the focus of this report is on racial equality, but it was quite interesting to read the white responses too. And the responses, whilst different, follow very similar trends. And all of them are at odds with the NHS average. So, for example, these are 3 res indicators which deal with bullying from staff, bullying from managers, and equal opportunities. And kind of all of them are going in the wrong direction, whether you're white or BAME. So my question really was, we're not focusing too narrowly with this, are we? And kind of missing the wood for the trees, that actually what we have is a bigger issue than just an equality issue here. There are actually some underlying issues affecting people of whatever creed, colour, or whatever, or orientation. And we mustn't miss those messages while focusing on just one aspect of this is really the point I wanted to make. Because, I mean, if you look at it, for example, we're below the NHS average on all 3 of those indicators, and that isn't a position where we really would want to be.
No, well picked up. Thank you, Yvonne. Before I come back to Rachel, I want to go to Yemisi and then Rachel to answer finally, please. Thank you. Yemisi.
It was just a quick response to Ray's comment about the front sheets. Thank you, Ray, for your email with all the questions about PQAC yesterday. I have responded back to you. And in relation to the front sheets, it has been mentioned to the relevant authors. There have been some improvements made, but obviously we have a way to go with it. But thank you.
Thank you, Yemisi. Rachel, please.
Thanks. So thank you, Yvonne. That's a really helpful observation, and I think you're right to point it out. I will say that when we spent a lot of time this time last year really listening in depth to the experiences of our Black, Asian and minority ethnic staff, we were very clear that the things that they identified needed fixing, we were going to fix for everyone. So these are not interventions which are designed only to benefit particular groups in the organisation. They apply across the board, and hopefully everyone will see the benefits of some of the issues that have been raised. But what we wanted to do was tackle the ones that they saw as the kind of the most burning platform, if that makes sense. So that's where we started. So our work on bullying and abuse from staff to each other, we are trying to take through in a range of ways, but probably the clearest is around our behavioural framework, which underpins our new values, and that sets out very clearly what's acceptable and what is not acceptable, and that's being built into all of our performance processes, into our leadership development for our managers, and across the board that's going to be in everything that we do, like a stick of rock. So real clarity about what those expectations are. When it comes to abuse from our patients, since the beginning of the year, we've had a really lively group looking at violence, aggression, hate crime and abuse from patients towards our staff. We've worked with the Met Police and more widely now on Operation Cavell. We've got what we're developing is a 4 Ps approach. So there's about prediction, prevention, supporting people and prosecution, which is about trying to make sure that we are really clear with patients about what they can expect from us, but also what we can expect from them, and how we will follow up if there is abuse and bullying against our staff. So that's been a bit of work that's been going on for a long time, but it's really, really taking momentum now. And so that's a big focus as well. So you're absolutely right. These are problems which are particularly an issue for some of our Black, Asian, minority ethnic staff, but they apply right across the board, and we need to tackle them right across the board.
Thank you, Rachel. Leslie, please.
I think most of it's been covered now. I was just going to make some of the similar points that have been made by Yvonne and Ray, but just contribute that I think what you're doing is great. I think we should celebrate the improvement. It may have been very bad, but it's now bad, so that is improvement. And when it's up to date, it may be better, which is all very positive. I thank you for all the hard work that's been put in. And I feel really positive because this is my last meeting. I've been here 9 years, and these things were raised probably at least 3 years ago. And as you already mentioned, there's sort of mindset that operates sometimes within the NHS about, well, you put up with that, or these things take so long, that'll never get dealt with because that's historical. I'm really delighted that it may have taken however many years since it's been first raised and pushed, but to hear that it's actually progressing and things are being acted upon, and there are new, fresh mindsets that aren't NHS entrenched, I find really rewarding and inspiring. And I'm leaving thinking, whoa, it wasn't all a waste of time. There is change. So thanks everybody for the work that you're doing.
And thank you, Leslie. We're going to miss you. I mean, you've been a really, another critical friend. You've challenged us a lot, and you've been a major part of what we've done over the last few years. So thank you for your contribution. But I think this is a really good discussion. I think it's right that there's a real challenge on this. We've talked about how important our staff are to us, but I want to recognise the work that that has been done on this. I think there's huge commitment. We know there's a lot more to be done. I almost get, that's a difficult phrase, that, because you think, well, let's just get on with it. But I know there's more to be done. But I know the passion with which Rachel leads this, the personal drive and energy that she puts into it, and Nina and Yemisi and everybody else that's been involved in this. There's real genuine passion to get this right. And it's absolutely right that the governors challenge us on this. But I also want to acknowledge, I think, the superb work and effort that's gone on so far without in any way being complacent. We know we've got a long way to go, and it'll be never ending, I should think, but it's going to keep improving. And we'll talk about it in a lot more depth next time around. But thank you. Particularly thanks to you, Rachel, for everything you do on this. And I know what an inspirational leader you are on this. And the feedback I get from the staff networks and others is extremely positive. So very, very grateful for what you do. Right, we'll move on next to something completely different. We'll now talk about Southwest Prisons. And Lawrence, please, and Michelle.
Oh, hi, thank you, Andy. I had to turn off my camera because I'm at the Bracton Center and we're having a bit of technical challenges, but thank you. We presented a short paper here just to inform our counselors, governors, the direction of travel for a different business opportunity for us for the Directorate in Prison Services. There's a huge procurement in the Southwest England area, and we're in the process through approval with the Business Committee of the board to submit. We submitted the draft proposal for this, which is a two-part process. There are 11 prisons in the Southwest area, worth of the yearly amount is about £39 million, just over, shortly, a little bit over that. The two-phase process is a short overview of 6 questions for each of the 4 lots, which we submitted earlier this month, and then the final bid would go in December. But I do want to bring to everyone's attention that because we have the 4 lots does not mean that we will be putting in a final bid for all of the 4 lots. There's a lot of work that has to be done in terms of making sure that we can deliver services out of each of these lots, and because these are quite far from the center of the trust. So we're taking a very cautious approach, doing a detailed analysis of all the issues and the challenges that will come along with managing further afield than we currently do. So we're keenly aware of the lack of isolation, not feeling connected to the trust, and the things that we need to do around building relationships in a different area, working with commissioners and partners that would be new for us. So our approach to this, if we are successful, depending on how many lots we bid for, we would create regional teams of infrastructure that would include senior management oversight, but it would not, we would have senior managers here, but we'll have regional managers in the area. So it will be a lot of oversight. And part of my challenge for myself and my senior team is connecting to Oxley's as a trust and our values and all the things that we are about. And it is my job and my challenge to make sure that staff feel connected. We are working locally with our 11 prisons now to do that. Do we have issues with some of that? Yes, we do. Do we have plans in place to tackle some of those issues? Of course we will. And we are doing that. So this direction of travel, even though it looks really good financially, initially on paper, is the devil is in the details. And that's what we're working through for the second phase. And that will go on from, we're waiting to get back feedback on our draft submission, which we'll get back hopefully in October. And then we'll take whatever feedback from that and we will incorporate those into the final bid. So happy to take any questions. Unless, Michelle, you want to say anything?
No, I think you covered that perfectly, but I'm here on hand to answer any questions if there are any.
Yeah, thank you very much, Lawrence and Michelle. Any questions at all, colleagues? Ray, please.
Hi, thanks, Lawrence, for that presentation. I just want to highlight something and see what you think about what I'm highlighting. So in your summary, you talk about the work to secure Oxley services in the Southwest as a business opportunity. Within the paper, you talk about markets continually, and then the first key benefit of this project is I'll just quote what the paper says, that the bid, if successful, secures Oxley's as the largest NHS provider of prison health services. Largest provider, business, markets. I just wonder about that language, and is Oxley's a business concerned with markets, or are we more about services for vulnerable people?
We're more about services for vulnerable people, but the reason I use markets, it's business language, because this would take us out of our normal geographical place, which is, Kent and London. This is going way afield from us, and so I use the terminology market. I could call it a geographical area, but I use the terminology of market. Happy for the challenge there.
I just wondered, Lawrence, when you list the key benefits, that maybe the first key benefit is to secure good health services for prisoners, rather than securing Oxley's the place as the biggest provider of prison services in the country. That's all.
Okay, thank you.
Ray, can I come in on that actually? I think one of the things is that we did some market analysis about provision nationally in prison healthcare, and I think we feel that the model that we deliver within prisons is a really good one, and it is very patient-centered, and we do feel passionate about our patients. And for us, it isn't about money. And our main competitor is a private sector organisation, and I think that we felt that the services that we could offer would keep the patient at the centre of that. And I think that has recently been confirmed by our success with the Kent bid. And I also think that that was some of the feedback that we got as part of the Gatwick IRC, which sadly we were unsuccessful in, but actually we learned a lot as part of that process. And I think one of the things about Gatwick, and we did have a wrangle in a similar forum to this about the ethics of it. And actually, we ultimately submitted that bid because we felt that the service that we could provide to the patients at Gatwick would have been a more patient-centred one than some of our competitors. And that was one of the reasons why we went for that. And I think The other driver for us is that we know nationally that these opportunities may not present for very many more years, and I think that we felt that we could make a real difference in the market and make a real stamp on that. And we've had some excellent feedback about the services that we do deliver as an NHS trust in comparison to some of our competitor organisations. But absolutely, I think we do keep patients at the heart.
And just to finish, Michelle and Lawrence, because I've heard you speak a number of times, and I'm convinced that that's exactly what you do. It's just that this paper comes across as if we're Price Waterhouse or someone. That's all.
Apologies, Ray. I'm an American. That's probably my capitalist Americanism. So I'll apologize to everyone for that.
No need. Just a point.
No, I mean, it's an interesting point, that one, because this paper is for the Council of Governors to note. What I can say, and in support of what Michelle was saying, that when we discussed Gatwick, we discussed that in real detail, particularly driven by Suzanne and a focus on ethics. And one of the things we were saying, as one of the reasons we were doing this, that we felt we provided really good quality caring service. It actually wasn't much of a business opportunity when you looked at it, but we really felt passionately that some of the most vulnerable people in our society, they deserve a good service, and that was very much one of the drivers. And when you see the bids that are put in, I mean, you see the feedback that we get. It's incredibly detailed, and the work that is put in by Lawrence and Michelle and others really does emphasise very strongly loads of issues, but particularly around the care and quality that goes into it. So I think you're right to raise that point, Ray. It is only it's a snapshot of a huge amount of work that sits underneath that. And I think that the point that Lawrence talks about being far from Oxley's, I mean, in the past we've been quite hesitant about going for anything that wasn't coterminous with us, not just within prisons, but with other services as well. But I've been reflecting on that over time to think, well, if we're confident in what we do, if we think we're good, then I think we can do that in a number of places, so long as we have that leadership, management oversight, care for local staff that Lawrence touched on, and that will be very much part of how we take this one forward. But anyway, thanks very much for that. Did I see another hand up somewhere that I might have missed? Sing out if I have. Was it John? Did you have your hand up?
Yeah, Andy, I was just going to pick on Ray's point, but I was going to also ask Lawrence that, I guess, in view of the ICS discussion we've had earlier, are there opportunities, I guess, to collaborate with others if we were going forward with the bid?
Well, we are collaborating with a number of subcontractors that we're working with. But if you're talking about collaborating with another NHS provider, like another trust, that would be, I think, would be difficult at this point, because we've actually have made some inquiries in the past recently about working together with other trusts and not competing with each other. And I think in London in particular, they've decided that competition is better in some aspects of it, and rather than working collaboratively. We still believe in collaboration as an approach, but we have to have willing partners that are willing to join us in that approach. But we still go after collaboration where possible.
So, okay, thank you. There's someone else who's there?
It's me, Andy. It's Michelle. I was just going to follow up on that and to John's comment. I mean, I've spent most of my day today actually working on the Southwest tender and building exactly those collaborations, and had some extremely exciting conversations. We're striving to get the best GP offer for the patients. We want to have the best substance misuse partner, which is really key. I've had conversations with Bernardo's, which could be a really exciting opportunity in prisons and more widely, really. And in addition to that, we've been approached to do some Hep C elimination work, which would bring in some additional funds to support our services, but actually make our bid a bit more unique. So, I'm really hopeful that the collaborations that we're building now are going to really set us apart from other providers.
Thanks, Michelle. Suzanne, please.
Sorry, Andy, I just wanted to sort of comment on the Kent bid, which is just to be clear that we don't know officially yet that we have been successful in that bid, and so it's not something that can be shared outside of this meeting.
Yeah, Michelle, where are we on the standstill?
The standstill is until Monday, the 20th, around 5 p.m. So we do need to keep that within this meeting.
I have to say, though, it is the world's worst kept secret. Everybody and their auntie seems to know the outcome.
Michelle, we are in a public meeting at the moment.
Okay. We've raised a clarification question with the commissioners in relation to the 10-day standstill period, because we have been approached by organisations external to Oxley's who have been made aware of the outcome of the tender.
All right, okay, thank you. Right, was there someone else there?
It was myself, Andy.
Oh, thank you, Ezra. Yes, please.
Hi, I just wanted to come in on one point that Ray had made. So I completely recognise the tonal aspects that you were raising about the report, but just as Director of Finance, I do feel I need to state it is incredibly important that we can actually live within the envelope of any bids that we give, because the quality impact of not doing so basically deteriorates quality across the length and time of the overall contract. So that piece of analysis and making sure that it is actually something that is financially viable is incredibly important for the services that we will then continue to deliver under the life of the contract. I recognise that may not have been the issue that you were raising, because I think it was a tonal point, Ray, but I think it's quite important that we always keep that in mind.
Thank you very much for that. Anything else at all on this topic? If not, we wish you well with all of that, and no doubt we'll hear a bit more in due course. Now, it says here we've got a 15-minute break. I think it's a shade generous, don't you? Do you think we could come back at 4, which gives us about 9 minutes? Would that be all right with everybody? I see lots of nods. So if we can come back at 4, please, I'd be very grateful. Thank you. Well, welcome back, everyone. 4 o'clock by my clock, anyway. Right, we'll go on to the comprehensive inquiry, please. Suzanne, Jane, whoever's going to present on that. Thank you.
It's actually going to be Neil Springham presenting because he chaired it. He's kindly offered.
Thank you, Neil.
Okay. So very happy to present this, even though it's an extremely sad experience that we went through. So this is an inquiry. I was chairing. And Suzanne Shale was with me, and John Bear, who's on the call today, was part of that review. So you will have seen the report. It's a comprehensive investigation. Mr. A had been under the care of Greenwich Older Community Mental Health Team. He was admitted to Scadbury Ward 10th of December 2020. The incident that we're talking about occurred on the 28th of January. Mr. A was reviewed at 9 a.m. He reported that he had felt worse since his admission, and he continued to have suicidal thoughts. This had been a constant feature throughout the whole of his admission. However, that was contrasted with staff observations which showed that he was becoming more social, seemed brighter, more interactive, was gaining weight, and was enjoying his food. So there was a difference of perception there. At 16:26, Mr. A tested positive for COVID-19, and he was to isolate for 14 days. So he was put into a side room, and on that same day, at approximately 17:45, Mr. A was found by ward staff to be unconscious, not breathing, and appeared to have self-ligatured. Upon Mr. A's discovery, CPR commenced, and he was subsequently conveyed to the Princess Royal by ambulance. He was unfortunately declared deceased on 9 a.m. 29th of January 2021. So that gives some very brief outline. I think what I would like to just let colleagues know is that this was a very, very pressured situation with many unique features. So when we look at the findings, we need to bear in mind the context that this was 9 months into the pandemic, that actually staff were having to work extra long shifts because there was a shortage of staff, because a number of staff through agencies did not want to come and work on the wards. There'd been a COVID outbreak on the ward, and that had resulted in a high level of infection control procedures needing to happen, which meant that that actually added a lot to the staff experience. Mr. A had himself received 3 forms of bad news on that day. So it wasn't just that he'd been told that he was COVID positive. He'd had information about his diagnosis and prognosis, and also the impact that that would likely have on his living arrangements. So it's a very powerful set of events, and our job as a committee was to try and find what was generalizable from something which had some very, very unique features. However, our findings were that the systems in place to form environmental and clinical policy and practice relating to ligature prevention did not address an unforeseen risk, that of self-ligature, through combining a number of shorter, freestanding items which had not previously been taken to be a hazard. So Mr. A had a background in sailing and fishing, and he had a great deal of skills with tying together short sort of pieces of rope, which surprised us. This was a new risk that had not been seen before, so there wasn't any information about that. So that's the context for that one. The system in place for recording and communicating update risk assessments and mitigation relied on documented entries and in care plans before the completions of the staff member's shift. So the policy states that you have to write something before the end of your shift in order to communicate things. This does not constitute a robust and timely means of communicating change in a patient's risk status on a busy ward environment. So if you remember, I was describing an extremely busy moment on this ward, where it would have been a great deal of face-to-face time needed, that actually just even writing things in the notes needed to be we needed another way of communicating changes in risks, such as having bad news. The system in place for advising the risk of masks could present to patients did not include guidance on how to mitigate the risks, such as a protocol for ensuring patients could not access their mask when they're in the room on their own. So remembering that this is a patient who needed to isolate for COVID reasons, and he was alone with the mask that he was eventually able to tie together with other shorter pieces of rope and string. There is currently limited training for mental health staff on how to manage and prevent the presentation of bad news to patients, such as cancer diagnosis, or in this case, the positive COVID-19. And a challenge long recognized in other areas of medicine. So what we identified was that on a busy ward where very, very practical imperatives such as risk, infection control were happening, sometimes the whole issue about the particular impact of being isolated and being given bad news and then isolated would have on a person's history. So for this person, sadly, this was a big issue for him to be isolated, particularly when he was left alone with his thoughts. Next slide, please. So our recommendations. The ligature point management policy should be reviewed to incorporate the understanding that combined shorter articles now form a ligature risk. Also, the use of alternative face masks should be considered. Number 2, a robust system needs to be in place to ensure that high-risk information or change to the care plan from ward rounds assessments is verbally shared with staff immediately, even during exceptional circumstances. So this is about teams being able to talk to each other and not just relying on the policy, which is the then policy, which was about making sure you write something down before the end of the shift. The trust is to consider providing training to all staff in breaking bad news. This should include the use of holistic risk assessments and reflective practice in the ongoing management of the situation. So this is about balancing physical risks with psychosocial risks and just trying to treat both equally. The trust should develop a harmed patient pathway so that frontline staff have clarity about the communication needs following a serious incident within the services. So staff told us that they felt there was not much guidance around about how they should talk to the family or who should be talking to the family about particular events as they unfolded. And this was particularly the case as it was across 2 trusts. It was between us and the PRU. And then a key learning area, which is something that we've been considering for some time, is the older people's mental health demographic continues to evolve in relation to self-harm and suicide risk. Age or cognitive impairment cannot be considered to be a protective factor to the degree it had previously. So this is a demographic shift over time, that the people entering services at that age of 65 have greater risk, have been through different cultural experiences, which mean that they have, in many ways, more similarities to the populations in the working age adult population. And we need to just keep an eye on this, this changing picture, which is a national picture. Okay, so that was the presentation. Don't think there's another page. Wondered if there were any questions on that.
Neil, who takes forward those recommendations now?
So the policy has been addressed. The nursing directorate and obviously we now have Aisling in the crisis care sort of pathway will be leading on those, as I understand it. Yes, so we have various sort of ways that will be going back into the sort of the main machine of the sort of organisation. So we put those back to the policy and then it's for the local directorates to enact those?
Yes, I was just looking at things like the alternative face mask, for example, about how practical is that? Is that possible? Jane, can you help on that?
Yes, I can. That was explored by Helen Nichols, our infection prevention and control nurse, and there isn't an alternative source. So what we've done instead is we've strengthened the advice that we give to clinicians so that they don't leave people with masks in their rooms, and they're making sure that they're only using masks when they need to and that they're supervised, so it's much stronger. This was a really, really interesting and unforeseen use of a mask that we haven't heard of elsewhere, and how it was combined with other articles in the rooms make it incredibly extraordinary. But Vicky's and her team, her quality team, done a brilliant flash alert as well to highlight the risk. We've also subsequently taken a risk from another organisation where some newspaper was tied together to form a ligature, and we've sent out a flash alert about that. But the policy in using face masks and distributing face masks was felt to be more realistic and practical in achieving than trying to source a face mask that wasn't out there.
Thank you. Yvonne, please.
Actually, it was on the subject of that face mask as well as I wanted to say. I mean, are we happy with that answer? I mean, I appreciate what you said. We've done what we can to mitigate the risk within the boundaries of, the current situation. But is there not some line up which we can be feeding that says to PPE procurement that in the case of mental health wards where there is real serious risk of self-harm, that there ought to be a more robust type of mask that is made available? And is not some route, do we not have a duty of care to kind of pass that up the acquisition line, or procurement line, if you know what I mean?
The outcomes of all the incident reports are shared with the CCG and with NHS England, and they are raised with the National Patient Safety Leads. So there is a route to collate emerging information about risks such as these. I think the difficulty is in a pandemic when the greater risk and more likely risk is transmission of COVID, we have to keep it proportionate, but it's a very valid question.
Yeah, I mean, if we do have any mechanism to emphasise that risk, I think we should do so. I mean, if at the end of the day the NHS chooses to ignore us, well, then we've at least done our bit. But that they're just kind of accepting the first answer, I don't think is the right answer right now.
Suzanne, please.
I have some sympathy for Yvonne's point, actually. I mean, I think there's... I think that we have to do what we can in terms of mitigating the risk through the action of our clinical staff. And I'm really pleased to hear Jane say that we've started, that's now part of our practice. But I think we also do need to think about how the environmental hazard can be reduced. And I'm not a designer. I don't know how that can be done. But I'd be surprised if someone in the world isn't already thinking about how can you make face masks that are suitable for use in what the Americans like to call behavioural health facilities. I'd wanted to comment more broadly on the action plan because I think that I'm grateful to Neil for doing the presentation on this case. I think that the action plan makes some really good points about the way in which the harmed patient pathway, which we recommended, should be conceptualised. And I think that what is being proposed there, really goes into proper depth in terms of thinking about what we need to do by way of supporting families, sometimes patients who survive, but also staff when something goes wrong. And I think that to anticipate that that's going to be coming forward by January 2022 would be really excellent and put Oxley's at the forefront of trusts who are trying to do better by all those groups of people after there has been harm.
Yeah, thank you, Suzanne. Leslie, please.
Yeah, I mean, there were a lot of amateurs, I'll say amateurs, it's the wrong word, craftspeople who were making masks for the NHS so that nurses wouldn't be without them, and they were handing them in. And Velcro comes to mind, more material and using Velcro. That there must be something around that. And there's people within the NHS, carers types, those types of creative, crafty people, that if you put it in the magazine that goes out to members and ran a competition for somebody to design a mask, I'm sure it would be cost effective, because these people don't make things that are very, very expensive. Just an idea.
That's a good thought there, Leslie. Thank you. Claire, please.
I just wanted to ask Neil and possibly Jane in relation to the delivering bad news training about what this would look like. I mean, it sounds like, because we almost have an expectation on our mental health staff of sort of having that skill, but it actually really is, you know, a very specific kind of skill. So I just wondered, you know, what would it look like really for the staff? And because I know we're talking about the mask, but I'm thinking sort of early intervention. Was that something that was, you know, really triggered Mr. A?
Yeah, I'm happy to come in on that. So when we were looking at that, one of the things was it isn't just breaking bad news, but it's assessing its impact, not just in terms of the practical things. You know, in that case, it was that this individual needs to be isolated, and we need to make sure that we're managing the infection control. But it's really linked to the idea of really understanding someone's social background and the kind of triggers that are there for them, psychologically speaking, so that we know that news will land differently for different individuals based on their history. So it's understanding the history, trying to think about the particular effects it will have for that person, but then linking that to the way that we consider risk and communicating that to the team. So it isn't just about using a form of words that is sympathetic. It's about just trying to make sure you keep the balance across the sort of biological issues, the psychological issues, and the social issues. And that's at each stage. So understanding the person, particular impacts that things may have. So in this case, it was that isolation was a particular part of this individual's anxiety and was quite triggering for him. And then how we would make a plan and communicate that across the team. There are examples around, and we want to kind of look at those. I don't know, Jane, if you wanted to come in with anything on that.
No, I think one of the areas that we're quite keen to explore is simulation and how we can use different ways of preparing people and practicing and learning. So that's going to be part of the proposal that we're hoping to design collectively with some of our teams and working closely with Neil as well.
Thank you.
Yeah, thank you. Steve Pleasance, please.
Yeah, this is a question for the panel who heard the thing. One thing that concerns me that didn't come out was the fact that this gentleman received some other bad news that particular day. He then got COVID infection, was then put into his room. I would like to know, were the observations then increased to this gentleman? Because obviously he could become quite unwell quite quickly with COVID. And that's one thing that just concerned me. But also, coming back as well to the friends and family thing, maybe him having his mobile telephone with him, he could have communicated a bit easier with the outside world. And then, I mean, I wondered if that was the case in this particular circumstance.
Thank you, Steve. We did explore those issues. The observations would be increased, we found, because of the COVID infection. What we wanted to make sure was that those observations would also be mindful of the impact of the bad news as well. So it isn't, you know, in fact, what happened was that there was actually a very short time between the staff seeing this individual and the incident. So this was a matter of, I think, 15 minutes, as I recall. So the observations were increased. On an older people's ward, there are challenges to using technology to stay in touch with family and friends. I think that's changing with the demographic, but that was something that had been explored. So there was a range of observations, but the whole issue is about making sure that we just keep an eye on a range of factors, not just the infection control, as it were.
Thank you, Neil. Are there any other questions at all? Jane, just remind me when we come back and revisit these recommendations, when would we come back and have another look at them?
We usually take the 6-month report following a presentation at board to PQAC to update on the completion of the actions, and we monitor the completion through the patient safety group. And with this one, it's also through the mental health safety forum. We've got a key focus on ligature management there.
Right, thank you. It just yes, it'll be interesting to see where we get to with these. This is some very good questions from governors there, I think. Are there any other questions at all? If not, thank you to the team, Neil and Suzanne, for the work that went into this. It's a very tragic case, but thank you for that report, and we'll look forward to hearing further about that in the future. We'll move on now to quality management framework. So that's MSc Vicky Gemma. Who's going to present on this?
Andy, I'm going to do the introduction and then pass to Vicky, if that's okay.
Okay.
I was also going to mention, talking about what we've, the serious incident, as we've mentioned, the updates do come to PQAC, but we are happy to provide a summary to the Council of Governors, as and when we get them, so that everybody's informed, if that would be helpful. Okay, so talking about the quality management framework, previously we had mentioned that we've adopted a QMF approach to help us to achieve sustained improvement in quality, safety and experience of the services that we provide to patients. And QMF has 4 components, so that's quality planning, control, assurance and improvement. And today what we wanted to do was to provide an overview of the new methodology that we will be using in the planning phase, which is different to what we've done prior, in order to identify our quality areas of focus and quality priorities in light of the QMF framework. So if I could pass over to Vicky, thanks.
Thanks, MSc. I just want to also provide, if possible, some clarity on the role of the Council of Governors regarding the annual quality report, and also go through the quality planning process as MSc's just described. Initially, I thought it might be quite useful to explain the annual quality report requirements for any new members of the Council of Governors. So in a normal year, we would have to be compliant with 2 pieces of guidance for the annual report. The statutory requirements of the quality accounts is applicable to all healthcare providers is one of those requirements. And then the NHS-EI mandated requirements for foundation trust. But the only difference between these is the annual quality account needs to be the same substance and same guidance within both of these reports. But the NHS EI mandated requirements also includes the ability to have it audited, externally audited, and also it needs to fit in with the annual reporting timescales. So it needs to be done earlier. So normally the quality account needs to be produced by the end of June, but the quality report needs to be produced by the end of May, but they are in fact the same report. So I just mentioned this because over the last 2 years, we've had different guidance has come out. So the NHSIE or EI requirements have not been required over the last 2 years due to the pandemic. So we've only had to be doing the quality account guidance, and that's why we haven't been doing the local indicators selection, and the report hasn't been audited for the last 2 years. We haven't got any information yet about this year's, about whether this is going to be following the same guidance or whether we're going to still continue to do the quality account guidance. So what we're doing is preparing you as a Council of Governors just to be aware that we might be coming to you for the council for the other requirements, but we aren't definite sure yet whether that's going to be required or not. So I'm just going to go through just quickly the 3 requirements that are required for the Council of Governors. The first one is the final report. So as you received probably in June, July time, you received a copy of the finalised report, and that is as part of your duty to hold the non-executive directors to account for the performance of the board. So that will always come to you shortly before or after, shortly after it's been approved by board, so usually in June or July. The second one is the selection of local indicator for external audit. And as I said, this is only required if we are required to do the NHS EI Foundation Trust guidance. And that is selecting quality priority for indicator selection for when we need it externally audited. And I'll come to the committee in usually December time to have a discussion about that. And then the last one is the selection of quality priorities. And this is where we changed it slightly. In the paper in the pack as describes our new methodology for the identification of Oxley's areas of focus and quality priorities. We have a new process in place. We must always have 3 metrics for each of those 3 different areas, the DARSI 3 areas, which is improving patient safety, improving clinical effectiveness, improving patient experience. But in previous years, we've always gone with the same methodology of having these 6 outcome areas. Well, now we're doing something slightly different, where we're looking at trying to engage with the public, patients, population, staff, and all the subgroups within the organisation to develop what our quality priorities will be to ensure we're using quality improvement methodologies to improve the ones that are the most have the most impact on the organisation. So I'm not going to go into a great deal of detail about it because you've got the information in the pack there, but if anyone's got any questions on it, the pack also describes what our areas of focus are for next year, which we will be monitoring, and also the areas of our quality priorities that have been selected for this year. Okay.
Thank you, Vicky. Any questions at all for Vicky on that? Ray, please.
Hi, Vicky. Thank you for that. So, Vicky, if the Council of Governors agrees the 7 priorities in red, what does that mean for the other priorities? For example, risks of self-harm with suicide, including ligature. That's number 3, isn't one of the 7. So what will happen there?
Okay, so all of the areas of focus are monitored through our subgroups. We always have monitoring of all of them, so they're all areas of focus will be monitored. What we're doing is selecting ones that will be our priorities for improvement. So we have to find the areas that have the greatest impact or the greatest risk for the organisation each year, and that's what we're developing, and that's what we go through the process of consultation beforehand. As in previous years, we haven't gone through a very, very big consultation process, but that's what the change in the process is going to be going forward. From this month onwards, actually, we're starting the process of looking at how we select the quality priorities for next year to making sure we have got the right ones. But I can assure you those other metrics are all still being monitored to make sure nothing slips away, and there's still work going on, and they're still priorities for the organisation, but they're not just our key priorities that we've got to show improvements on.
Can I just say, Vicky, again, I've seen lots of examples of this. I kind of think, I wonder about such exercises because, of course, we won't be ignoring number 3. We've just been discussing it. So it's to say that 7 are going to be more special. Well, I just find it a very funny thing. That's all.
Unfortunately, Ray, it's our mandated guidance. We have to do it.
Right.
We have to do 3 from patient safety, 3 metrics from patient safety, 3 from clinical effectiveness, and 3 from patient experience. So it's something we're mandated to do. And obviously, if you have too many quality priorities, there won't be priorities anymore. So we do have to make sure we have those key priority areas that we're focusing on. And I think from next year, as we change to more of a trust-wide approach to QI as well, we'll be looking at how we can identify those ones that can be real quality improvement projects that will really make a big impact and the changes to the whole organisation rather than just selected ones. We're also looking at how we can work with the directorates to develop their own quality priorities for each directorate. So as you see at the end of the paper, we have mentioned that we are doing them for prisons, ALD and CYP, because these are overarching ones, don't necessarily match their priorities for their directorate. And that has been having a really good impact at the moment, actually. They're really taking them seriously and developing what the improvements they need to do in their services and align them to other work they're doing.
Sure, because I would have thought that number 3 is very suitable for prisons.
Yeah.
And
they've got that as well. Sorry, they've got that as one of their priorities, ligature risk.
And just say something that it relates to the previous discussion too. So in prison, some prisoners are under constant watch. and it might be useful to look at the criteria used for those prisoners when applying to people who might be isolated in our wards. Just a thought.
Thank you. I'll take that back to Christine. Thank you.
Thanks.
Vicky, could you just remind us of where this requirement comes from?
There's a guidance from NHS providers that's been sent. I think Joe's got a copy of it, haven't you, Joe? I think we could circulate it if you like. It's all the guidance is in there.
Is it? I just wondered what's its basis, whether it's based in legislation, based in NHS EI requirement, or if is it guidance from NHS providers? Ray's got a really good point, actually. You know, one of the things that worries me is everything becomes a priority. We've got no end of priorities coming at us from all sorts of angles, and it can after a while get slightly confusing. And
Oh, sorry, Andy. The guidance for councillor governors' responsibilities is the one that Joe's got. That's NHS providers. The statutory guidance that comes out for the quality accounts, it's very rigid. It's exactly what we have to do. It's statutory guidance. They couldn't change it during the pandemic because it was in law. It was statutory. So we have to follow that to the letter, even to the point where the report is written in a way that it doesn't really make any sense really, but we have to do that.
Yeah, okay, well, interesting. Sue, please.
Very much. Just a quick question. In terms of the method of the suicide, it's obviously very exceptional, given that he obviously used a mask or whatever he used attached to that mask. Is this the only case of its kind as far as you're aware?
I can actually answer that. Yes, it is a very unusual case, and that's why we did the flash alert straight away, because we wanted to make sure that people are aware of the risk of the gift bag and the mask and the pen, because it's a very, very different way of anyone ever. And when we spoke to the CQC about it, they were very, very shocked about the way that this happened as well. So, yeah.
So sadly, people who are intent on doing something, they will find a way one way or the other. But it's extremely distressing for everyone involved. But
Yeah.
Thank you very much. Thank you.
Thanks, Sue. Any other questions on this at all? If not, Richard, we move on to item 12, which is the NED nominations, which is over to you. And I think at this stage that myself, Stephen Dilworth and Nina depart, and then you call us back when you're finished with the deliberations. Sally, I think you have relevant phone numbers, I think. Is that correct?
I have. So if you can all leave the call, then I can text you to let you know to come back on.
Okay, thanks very much.
Right. Thank you, colleagues. I hope you've all had the chance to read the papers attached to item 12. You had a sort of forewarning of this at our June meeting, that we had several tasks to complete over the next few months. The nominations committee, as it says in the paper, met in the middle of last month, and we're bringing to you a number of recommendations asking for your approval. And I think one thing just to tell you what's happening. The first item I want to take is recommendation 1. Steve Dilworth and Nina Hingarani Crane are both coming fairly rapidly towards the end of their current 3-year appointments as directors, non-executive directors of Oxley's. Andy undertook some fairly detailed work asking many people, including governors, their views on Steve and Nina and whether they ought to be reappointed. And he brought to the committee on the 19th of August a strong recommendation of his views and those he collected from others, that both Steve and Nina should be offered a further 3-year appointment as non-executive directors of the Trust. So that's the first recommendation. Are there any comments or questions, or people happy to accept that recommendation? Because that is a decision of us as the Council of Governors to make that appointment.
Yep.
Looks like everybody is happy on that one. The second item that we considered was the reappointment of Andy as our chairman. The work on this was led by Steve James as the senior independent director, and Steve did consult very widely, again including asking governors for their thoughts. A copy of the paper that Steve prepared for consideration by the nominations committee is attached, and as you'll see then, there is again a strong recommendation that we should agree to Andy's reappointment for a further 3-year term of office. I don't know if, Steve, you want to add anything to what's said in your paper, or any colleagues have any questions or comments?
First of all, can I apologise for not having a camera? I seem to have connection issues today. And I'd just like to thank all the governors who took part in the process. It's a bit like other things that happened today. The process is given to us and can be a bit clunky, particularly for governors, because some of those questions, it's quite difficult to answer. How does Andy operate in partnership arrangements? I mean, some of us will have seen that and some of us won't. So I appreciate that some of the questions were a bit clunky. But I'm very happy to answer any questions that people have. As you can see, I consulted both within the trust and outside, and there is a universally positive view about Andy's chairing of the trust, and also a universal view that there are 3 things really that the next year or so he needs to concentrate on. One is partnerships, which we talked about. We had a presentation earlier about how important that will be, and I think he will play a key role in that. Secondly, seeing the appointment of a new chief exec, because I think a number of people made comments that continuity is very important at a time like this. And the last one was making certain that the views of patients and families were front and centre in the implementation of the strategy. So that if you were to look at things for the future, they would be it. But I'm happy to answer any questions people might have.
Did anybody have any questions, or are we happy to go to making a decision on that recommendation? Am I right in reading the meeting saying that we accept that recommendation?
Yes.
Yep.
Yes.
Thank you very much, colleagues. Sally, I don't know, is this the appropriate time to invite the 3 back in?
Yes, I'll send out some texts.
Okay, while Sally's doing that, the 3rd item, it says it's a recommendation. It is, I suppose, in the sense that it's just to note the update. We did have a discussion at the last meeting about the fact that we have to recruit a new NED because Steve James has to leave us the end of the year because he would have completed 9 years. I can't believe it's 9 years since you joined as a NED, Steve. And that process has moved forward and went through a number of iterations and discussions about exactly what the emphasis should be. But the upshot of that is that the advertisement and the process has now formally started. The job advert and recruitment pack have been available since earlier this week. Applicants are asked to contact Hunter Healthcare, who are managing the process for us, by the 11th of October, and there will then be a process of whittling it down so that a recommendation for a new appointment as a non-executive director can be brought to the December meeting of Council of Governors. I maybe take this opportunity just to say one of the things that we have thought very strongly as a nominations committee is it would be good to have somebody with some very strong local connections from our part of southeast London, and possibly somebody who has strong links in sort of the voluntary third sector and the like. So if any members of council have any thoughts on people who might be interested or organisations that could put out the advert, it would be very much appreciated. I know Sally's been doing some tweeting about it and the stuff on the Trust website and the like, but it would be good to have a strong team or a strong list of applicants to be considered. And although I won't be involved in any way, I shall look forward to seeing who it is. So that's just to sort of to note that bit. And welcome back, Andy, Nina, and Steve. Council of Governors are looking forward to working with the three of you for the next 3 years. Thanks very much for all you do for the Trust. And meeting's now back in your hands, Andy. You're muted, Andy.
Thank you very much, and I'm very grateful for that endorsement from the Council of Governors. And I'm sure that Stephen and Nina are as well. And I'm very grateful. They're two very, very strong NEDs, and you know, we have a good, strong team. And I think, were you talking just now about the next NED appointment, Richard, at that stage when I came in?
Yes, we were. I was just advising people that the process has now formally started and the advert is out there on various websites, including Oxley's and NHS England, but making a comment to colleagues that we were, you know, would be very interested, or you would be, because I'm not going to be around for this process, to see applicants with strong links in our part of London, and possibly people who have strong links into the voluntary sector and the like. So if anybody has any ideas, either of individuals or organisations that ought to be made aware of the fact that Oxley's is NED hunting, it would be much appreciated.
Yes, I totally endorse that, because I think we should be encouraging people who might not think of themselves as likely NEDs. So if you know anyone, then please do encourage them to have a look at the advertisement. And I'm particularly concerned, not that it's exclusive to that, but if we get people that really understand our three boroughs and would add some further enrichment to the board. You're going to hugely miss Steve. We're not saying goodbye yet to Steve, but and also working on with LGT means we'll still be in touch, but we have a huge opportunity to add to the board. Anyway, I again repeat my thanks to the Council of Governors on behalf of myself and my two colleagues, and then we'll move on to item 13, which is still you, Richard. I think we should holding NEDs to account. And you're muted this time, Richard. Richard, I think you're muted.
I'm doing the same again. Apologies. I'll handle this as I usually do, just have it as a matter of report for colleagues, and say if anybody has any points they wish to raise by exception, they're welcome to do so now. Or any questions?
Any questions for anyone on that? All I would add, and really great. Sorry, Ray, please come in.
Thank you very much. I just wanted to make a comment that over the past year I've had conversations with a number of NEDs before or after their various committee meetings, and I've got to say that all the conversations have been very excellent, and I found the NEDs that I've spoken to, I daren't name any of them because I'm bound to miss someone out, but all the NEDs that I've spoken to have been absolutely welcoming and very, very responsive. So I've been really grateful for that. That's all I wanted to say. Thank you.
Thank you, Ray. Sorry, Richard, you go.
I was going to say, maybe in conclusion, I would say I think we developed this attendance at meetings as very much an Oxley's-based approach when we had no real clear guidance on how we to hold NEDs to account. I think it's worked extremely well. It's working better and better each year. We're getting more and more experienced at it, and I certainly found it an extremely useful way of knowing just what's going on in the trust, getting to know the NEDs, and I think makes the job of all of us, whether we're governors or non-executive directors, so much easier by having this partnership of attendance at meetings, and long may it continue. I think it's something that many trusts could copy Oxley's to their advantage on.
Yes, thank you, Richard. I'm very grateful. We have a really good turnout, and it's a good challenge as well. I just think it brings the Council of Governors to life, because, as you rightly say, Richard, it means your knowledge is far deeper than just an attendance at a few meetings a year. It's right into the fabric of the organisation. Not only the meetings, but as things go live again, Joe, no doubt we're going to look again at doing visits for governors to go out to services, which I think again adds another layer of knowledge and responsibility to the Council of Governors. Thank you again for that. Right, okay, for nothing more on that, we'll move on to item 14, Membership Committee Report. Rebecca again, please.
Hello there. Sorry about my last article. I seem to have a network failure, but hoping to get through this one. So item 14 is about the membership committee meeting, and we had met on the 24th of June and the 2nd of September. The communications group was working through and developing a new hard copy newsletter, and that's going to be sent out. That work's ongoing. The engagement and representing members with the public working group is continuing to map the existing information and the other sources that have got the potential to provide a better way of understanding our members and public concerns. So we want to work more closely with them. Young People Working Group, the plans are working towards a promotional video targeted at younger people, and the work's going to be done in close collaboration with one or both of the further education colleges. And the Forensics and Prison Working Group update is that is still work in progress. We are liaising with Lawrence Mack, the new service director, and the prison interest group. So we're looking for some extra members for that as well. So the overall membership committee has received its updates in terms of the membership committee, the membership strategy, which we talked about earlier, and also looking at this year's annual members meeting, and talked about the Together 21 festival. In addition to this, we've been discussing the membership committee chair and vice chair, and this was open to all governors. Any governor wanted to put themselves forward to be chair or vice chair of the council of the membership committee meeting, and it has been proposed, if I can propose, that Sue and Simon, so Simon as a chair and Sue as a vice chair for the Council of Governors, would it be agreed that it's a governor-led committee meeting and all the governors had put themselves forward that wanted to, but we're proposing Sue and Simon to work together in this role?
I take it they're agreeable to do that, are they, Rebecca?
I believe so, yes. Yeah.
Well, let's take it. That's agreed then. Any questions for Sue, please?
Yeah, only just say that fortunately we had a conversation about waiting till we'd had the lead governor election results, and had a conversation with Joe, and decided that as I was fortunate, I think, to be elected as lead governor, it would be good to have somebody else to be the chair for the membership committee, and I'd be happy to be vice chair, because I think I like to be inclusive rather than exclusive, and having somebody else to do a lot work alongside me would be brilliant. So I hope everyone's happy with that.
Yes, that sounds like a good idea. Okay, can I leave it to you to sort out? That'd be okay. Lovely. Rebecca, anything else, Rebecca?
Yeah, if anyone's got any questions about the membership committee for what we've been doing in the last 3 months, happy to take any questions on that.
Well, it sounds to me like you've been very busy, and thanks again for the work you put into this. I'm really pleased that you're doing this. Thank you.
Thank you, and I have to say it's been a really great role to have. So I'm looking forward to Sue and Simon, and you know, any help that I can give them be brilliant.
And I think we will be asking you too, Rebecca.
No problem.
Well done. Thanks ever so much. Sally, Council of Governors Developments, please.
Thank you, Chair. So this report brings the outcomes of the elections that have taken place through the summer. Has the election report attached, and many thanks to everybody that has stood for election and re-stood, and also to those whose time of office has come to an end. So the actual changeover in the Council of Governors will come at the annual members meeting at the end of this month, and where we have new governors joining the induction session. Sorry, if people could mute their microphones, thank you. And we have the outcome of the lead governor election. So can I pass on my thanks both to Richard for all his time as lead governor, and to Sue and John for standing, and looking forward to working with you, Sue, in the future. As mentioned, the annual members meeting is at the end of this month, which we will be doing virtually again. And just to also highlight, although we haven't been able to meet as face-to-face, we have continued with our activities to try and keep governors involved within the activities of the Trust through both the informal governor meetings. Alison Furzer has recently been involved in one of those, talking about the digital developments, and also visits to services, but virtually. Happy to take any questions.
Any questions at all for Sally on that at all? As you say, Sally, we'll be able to say goodbye to people at the AMM, but also, of course, for some here today, it's their the last Council of Governors as well. So I've mentioned Richard already, and you know, Steve Turner and Sharon Rodriguez, Ray, Leslie, Margaret Cunningham is there. But I just want to thank you, and I think I really, over the years, I've just really seen the Council of Governors develop to much more challenging, much more vibrant, I think. Some really tough questions, which is what they should be. You know, that is your role, to hold the NEDs to account. But it's also been done in a very positive and supportive spirit as well. You know, for the good of the patients and for the good of the organisation, and I thank you for that. And it's not been without some quite interesting challenge sometimes. So I'm grateful for the energy that goes into that, and we'll miss you. You know, we're going to miss some of those faces and voices that we've had on. You know, being very much part of, I think, the development of Oxley's, and I'm really very grateful for that. Is there anything else on the Council of Governors developments? If not, we're into any other business. Is there anything from anyone else at all? Just a sort of, there's obviously huge amounts going on. Externally, you know, we've been hearing at the informal about the ICS, and there's a lot more to be done there. I thought everyone that was present to that was extremely polite. I think things are going to get more and more interesting about the future with the ICS, as we want to play our part as Oxley's. We want to be good partners. We want to work with the rest of the ICS, at the same time remembering that in current structure we are still a foundation trust, and we're still a sovereign organisation that's answerable in law for what we do, for quality, for care, for money, and all the rest of it. And I think this is going to be an interesting one, as how we steer our way through this. Ray, I thought you said the nicest things I've heard you say about us in your challenge to the ICS. at that meeting, because there are lots of pluses of the way the organisation is run. Without there's lots to do, as there always is, but it's how we maintain and improve that and work genuinely in partnership with our neighbours. We are developing our partnership with Lewisham and Greenwich. That's a real partnership. It's looking very much at how we work with them within A&E, how we work with them in intermediate care and other matters as well. But it's focused on real matters that we can make improvements upon. We've got a lot more to do with SLAM, as we have to develop a mental health collaborative with them. I do want to thank the exec. I think the pressure has been extraordinary over the last year, and I see now the more and more demands for meeting after meeting. You've seen today how they've been in and out because they've been going off to meetings all the time, and we need to watch this with the ICS to make sure they're not dragged into multiple meetings all over the show. We can't carry on like that. They haven't got time to walk about. They haven't got time to walk around and look at the services, which is an integral part, I think, of being a leader. So huge thanks to the exec. Big thanks to my fellow colleagues, non-exec directors, who do an awful lot more than their number of days for which they're paid. They've put a lot into that. And a big thanks to you as governors. Liz is cropped up, yes? Hand up. It's on my screen, Liz. Anyway,
hello there. I just wondered if there are any plans to resume face-to-face meetings.
Yes, good point. I mean, I don't know if Jane is still with us or she's been dragged away for Jane Wells. She may well have already gone for other things. Otherwise, I might pick a new Tom. But the I mean, Jane has to interpret. Oh, there she is. There's Jane. Just about the if we did face-to-face, the guidance where we are at the moment. I really would like to do face-to-face, but there's some interesting numbers around at the moment, aren't there, Jane?
Yeah, the COVID's not going away, it is increasing, and we are seeing a rise in hospital admissions, and the vaccinations are not protecting everybody from admissions. As healthcare staff, we have to abide by the infection prevention and control guidance for health staff, and nothing has changed. So it's exactly the same as it has been for the last 18 months in terms of social distancing, wearing face masks in offices and not having large gatherings. So if people were to have face-to-face meetings, it would have to be in very small numbers. They would have to socially distance 2 meters apart, and they would need to wear face masks. And the hardest thing that we would have to work out is if somebody did then test positively, we'd have to appraise the situation about contact tracing and subsequent isolation. So teams are proceeding with caution and they are sticking to very small numbers. I think probably the size of this meeting, it would be very difficult to have a socially distanced meeting just yet. But hopefully the guidance will improve, the situation will improve in some months, and we'll be able to progress to that. I hope that's probably not the news that you wanted, but that's the infection prevention control guidance that we're being given for groups, particularly of this size.
No, thank you, Jane. Leslie, please.
Yeah, I just wanted to say thanks very much to everybody for making the last 9 years so enjoyable and the involvement that I've had. Good luck to all the new governors and with all the work that you've got ahead of you. Thanks to the NEDs who've been very involved and receptive to the questions and putting them forward. So thank you very much for my time.
Thank you, Leslie. We'll definitely miss you, Leslie. But thanks for everything you've done. Sharon, did you want to come in?
Yeah, I just want to say thanks to everybody as well, being a staff governor. I've really enjoyed 3 years, but especially the staff assemblies. I think that's really making a difference to staff wellbeing in our directorate, and a big thank you to Jo for her continued support over 3 years.
Yeah, well done. Thank you, Sharon. And I want to endorse that to Jo, who's Jo and Anne-Marie doing all the work behind the scenes, and a lot of graft there. And thank you ever so much for everything you do. On that very positive notes, is there anything else from anybody else? If not, I shall draw the meeting to a close, and thank you all very much. Look forward to seeing hopefully at the AMM and then at the next Council of Governors after that. And who knows when we might meet face to face. Let's hope so. Anyway, thanks very much indeed, everybody. Thank you and goodbye.
Bye, everyone.